And I'm going to give you a perspective. So I want you to, as I'm talking, I want you to keep this in mind, no matter what I say. The guidelines, whether it's ADA, the new ADA guidelines, or the AHA-ACC, it's all about risk. It's not about the numbers, it's about risk. And so you're going to see some of the guidelines are a little overstated, but if you keep it in mind what the risk of the person is, then you'll see how much logic or lack thereof there is. So this is a brief history from 1997 to the present, and you'll notice that most of the time it was less than 130/80, and now the ACC, AHA kept less than 130/80. And what we did in the update of the blood pressure guidelines, which I co-chaired, was to take a look at the risk that someone would have in terms of 140/90 and 130/80 and look at the evidence that really supports this. So that's kind of what I want to walk you through. So the diabetes statements, this is from the AHA-ACC guidelines, basically said extremely strong level of evidence, less than 130/80. You should know that there's not one prospective trial that they quoted there. It's all coming from meta-analysis. So if level 1B is meta-analysis, that's pretty impressive because this group puts meta-analysis below a prospective clinical trial. So just keep that in mind. The second thing is that it doesn't matter how you get there, just get there. Now, I kind of agree with that, and I think that's an important point. And then the last thing is what I told you this morning. If you have 300 milligrams or more of albuminuria, you really do have to use an ACE or an ARB, and the evidence is pretty strong on that. Now, what did we say in the diabetes guidelines? Well, we said that you need to look at the risk, and if the risk is greater than 10% over 10 years, then you can be more aggressive. But for everybody, no question, you should be less than 140/90. And then if you have a high risk, then you should probably be less than 130. And we gave that a level C because the evidence is not overwhelming, because it does predominantly come from meta-analyses. And I'll show you some of those. The other thing we did in older people with diabetes, because of the small vessel disease and the high risk of coronary disease, we basically said that there's enough evidence to put in a statement about reducing or avoiding a diastolic of less than 60 for fear of the so-called J curve. And I'm going to show you some evidence for that as we get through it. So what data do we really have from primary powered clinical trials? Well, there's only two studies. There's the ACCORD and there's the UK-PDS. And the UK-PDS I'm going to take off the table because their notion of aggressive in the UK was 144. So I don't think anybody's on the same page there. Even the British have moved on. ACCORD, unfortunately, in spirit, when they started, was powered for a blood pressure difference. But by the time they killed everybody with hypoglycemia for glucose control, they lost the power for blood pressure. So we'll get back to that in terms of what the effects are, but you'll see what I'm talking about. We really can't make any statements. So this is the primary analysis, which you already know. And then they did a follow-up, a long-term follow-up, the so-called accordion, which, by the way, they never published. This is a presentation from the American Heart Association in 2015, and what you see here is two levels of blood pressure. You have the blood pressure from the original trial, a 14 millimeter delta, and very good stroke benefit. And then you have the long-term follow-up effect, and that 14 millimeters turned to 4 millimeters. Now, as you were talking this morning, there is a legacy effect from glycemic control, no question about it. There is no legacy effect from blood pressure control, zero. Wasn't seen in UK-PDS, it is not seen here. The stroke benefit that you saw early in this trial was gone in terms of long-term follow-up. So I think that's an important point to keep in mind. Now, I told you that they killed everybody with hypoglycemia. This is the interaction factors looking at the different groups. And you can see here the only thing that's significant is the intensive versus standard glycemic control group. And I think everybody's for controlling glucose, but not to get there within the span of 1 to 2 months, which is what they tried for in this trial. So one has to be very careful in terms of doing this. And so the data from the blood pressure here is now underpowered and not really interpretable. So what happened recently is a group of PharmDs got together and requested the data from Accord that matched the SPRINT trial. So they took the inclusion criteria for SPRINT, put a proposal together, got the data from Accord that matched exactly the SPRINT trial, and then did an analysis comparing intensive versus standard glycemic control, and they ended up with about 650 people, 630 people in the other group, and that's the basis of the analysis. And I want you to remember now, the guidelines say 10% 10-year risk. I'm not really sure kind of how they pulled that out of the air, but SPRINT had a greater than 15% 10-year risk. And the Accord group was probably equally at high risk. So here are the demographics, and if you can't see them in the back, let me just tell you there were absolutely no differences between the intensive group and the standard group that were looked at in this study. And the results suggested that, in fact, yes, intensive blood pressure control did do a better job in people with diabetes than the standard blood pressure control group. Now, this is very nice, but the problem is that, again, this is a post hoc analysis and not statistically powered. No regulatory agency would ever accept this. But it's an interesting proof of concept hypothesis, and then you could expand it. Okay, so now if we go back with the assumption of a 10% 10-year risk, and we say less than 140/90, where's this data coming from? Well, there are a number of meta-analyses. In fact, there were 6 meta-analyses when we did the studies, but nobody really talks about blood pressure level except 1 or 2 studies. But they do talk about 10 millimeter reductions. So wherever you're starting, if you're at 145 and you get to 135, across the board, you're getting a benefit. In fact, the only benefit that wasn't seen was renal failure. Everything else had a benefit if you can lower the blood pressure 10 millimeters and you have high risk. There was another analysis looking at even more studies. In fact, the denominator in this analysis was like 350,000 patients. And the reality is here, if you're looking at cardiovascular events, then here it does talk about level of blood pressures. But look at this. Less than 130, you could say, well, it's positive. That's fine. There's only 4 studies. The other studies at higher levels of blood pressure show a benefit. And interestingly, even here, if your blood pressures were above 160, you seem to get a benefit if you reduce the blood pressure, no more or no less than anything else. So again, not obvious that you need to be of less than 130. Now, the only really well-done meta-analysis that carefully looked at people with and without diabetes was this analysis that was recently published, 14 randomized trials and 10 randomized trials without diabetes. They compared the two. And they actually looked specifically here at people going on to dialysis. And the bottom line was that the number needed to treat 8 cases per 1,000 for 5 years. Now, here's the analysis, but I want to focus here. You can see if you're interested in the kidney, up here, the people with diabetes did get a benefit from the little lower pressure, but those without diabetes did not. Now, if you come down here and look at this, what levels of blood pressure are we talking about? Well, if you were greater than 140 or at 140, you got a benefit. But if you got lower, you didn't seem to get a benefit. And in fact, the range of blood pressures starting at baseline were huge, 126 to 187. That's what you started with. So it's very difficult to make a really strong assessment from these meta-analyses. The trends are there, But you really can't walk away saying there's no question you have to be less than 130. And so, in fact, contrary to the past recommendations in diabetes, there's little to no further benefit in lowering the pressure below 130 from this analysis. Now, there's a very recent paper. It's so recent that it just got accepted, so it's not even quite online yet. But one of the advantages of reviewing papers is you see this data before it comes out. And what they did is they went back and very carefully looked at the meta-analyses, actually looked at the achieved levels of blood pressure, and you can see here that there's no question that a blood pressure of less than 140 is very reasonable, but good luck finding evidence here that less than 130 is better than less than 140. You can't, and that's one of the points of this paper. Now, there's a Japanese study that was recently published, and this was intensified multifactorial interventions, but it looked at intensive therapy versus conventional therapy. It's kind of an expansion of the Steno trial, but done in Japan, and it's an open-label randomized trial. And again, here they looked at blood pressures in both groups, and you can see here that hemoglobin A1Cs were around 8, and systolic blood pressures at baseline were really very well controlled in the 130s. So this is a well-controlled group coming into this study. And you can see here what happened to blood pressure. Systolic is on the left, diastolic is on the right. And they already started close to goal and clearly went below goal and sustained that over the 9 years of follow-up. Well, the primary outcome is here. And unfortunately, the p-value is 0.09, did not favor a lower level of blood pressure. And in fact, the main secondary outcome, which was also MI, stroke, and all-cause mortality, didn't make statistical significance at 0.055. So it looks better, but it didn't quite make it after 9 years. But remember, these people were pretty well controlled coming into the study. What about stroke? As usual, there was a stroke benefit, just like you saw in ACCORD and in many other studies. And so there's no question there is a benefit from being a little more aggressive for stroke reduction. And here it was wildly significant. Now I want to make a point about the level of blood pressure, systolic and diastolic. Now this is an analysis that was recently published, and it was over 19,000 patients. And it looks at people with and without diabetes. Now you're looking at the curve of people with diabetes, and I've got the arrow there right at 130, because at 130, the risk starts going up. What about non-diabetics? That was SPRINT, that was a lot of the other trials. Oh, now it's 120. So if you don't have diabetes, your risk doesn't start to go up until you get down to around 120 or lower. And even then, it's minimal. So in people with diabetes, getting lower is not necessarily better, and the mean follow-up here is 16.2 years. So I think that's an important point to keep in mind. Now, there's another paper that just came out this month, well, last month, in Diabetes Care, and this is a Chinese study that looked at close to 30,000 patients. And basically, again, looked at people less than 140, less than 130, and less than 120. You can see the demographics here, and you can see that the hemoglobins, the duration of diabetes was about 7.5 years, and the blood pressures here are in the high 140s, low 150s, and again, hemoglobin A1Cs here relatively good, around 7. And here what they found in 28,000 plus people after 4.8 years median follow-up is there was absolutely no difference if your blood pressure was between 130 and 139 or 140 and 149, but if you went below, in other words, if you got down to 120, your risk was actually higher for mortality. So again, lower is not necessarily better. So we've covered that. Let me finish up by sharing a little bit of information for you on the J curve. Where's that coming from? Well, there's a number of studies. The on-target Transcend trial is one of the first showing diastolic blood pressures on the primary outcome and cardiovascular outcome. Once you get down to less than 70, risk starts going up. And when you looked at the diabetic subset, that trend was there and it was a little bit more magnified. And in the sprint, there's a recent analysis done on diastolic blood pressure, which was recently published in January of this year. And you can see here, again, non-diabetics, so I already showed you, non-diabetics are less likely to have a J curve than those with diabetes. And here, when you look at the quartile 1, which are the people with diastolic of less than 68, and you can see 42% had kidney disease, and 60% had a greater than 15% 10-year CVD score, that when you look at the primary CV event in the far left in panel A, I drew the line there where 60 is. You can see the risk has already started going up back in the range of around 70. You don't have to wait for 60. Same for all-cause death, and same for worsening kidney function. So even in non-diabetic disease, if the diastolic gets too low, you start seeing some abnormal trends. Doesn't come up so much with systolic, but it does with diastolic. So what did this lead to? The American Diabetes Association approached the American Heart to say, look, we need to come together. You accept our guidelines and we'll come with you, because we're essentially saying the same thing. And they took umbrage with our commentary about what I just outlined for you, that not everybody should be less than 130. How can we say that? And because of that, there was a big disagreement. So what happened is my co-chair got very aggravated and decided to get the three of us involved in writing kind of a treatise. And my suggestion was to put it in JAMA so that the entire medical community can read it. And so we did that. Now I'm not expecting you to read it, but I do want you to get some highlights out of there. And what we basically said is you can't have one size fits all. We basically said that each person is different. Diabetes is a different disease from non-diabetic kidney disease. And basically the ADA recommends distinguishing blood pressure thresholds used to diagnose hypertension from those of treatment targets. There's a difference. And similar with hemoglobin A1C levels. And basically saying there's no clear rationale to change the blood pressure thresholds to define hypertension from 140/90 to 130/80 based on epidemiology, because that's really what it's based on. So with that, I'll finish. And by the way, the AHA-ACC looked at all the evidence because they saw most of the evidence I just showed you, and they're now going back and revisiting that and seeing what they can do to not be embarrassed by what they said and kind of modify the wording. So that's where we are right now. But basically, there's no strong evidence supporting a blood pressure goal of less than 130/80 to slow CKD progression, unless you have more than a gram of proteinuria. Then there's no question you really need to have the blood pressure less than 130/80. But if you don't have diabetic nephropathy in the advanced form, there's no evidence that you need to be below 130. Yes, you should try to get to 130 or 132, but you don't need to be below that. CVD outcomes are reduced in patients with diabetes if you get to be between 125 and 130. But going below that, as I just showed you, your risk starts going up. So you have to be careful about that. And largely that's because of small vessel disease in diabetes that you don't tend to see in people without diabetes. The major guidelines recommend this. We already talked about this, and I already told you this morning about the RAS blockers. So that's kind of where things are in terms of the state of the art for the guidelines, the differences, and the rationale for the differences, and kind of what the future holds. So I'm happy to answer any questions or comments that you have. Thank you.
Thank you, Dr. Bakris, for a very important and informative lecture. The topic is open for discussion.
In diabetics with no high CV risk, what is that group? I mean, so in that group you would say 140/80, right?
Well, no, I wouldn't say 80. That's the old throwback. Let me tell you the problem with 80. 80 comes from the HOT trial, And the HOT trial only had a subgroup of people with diabetes. And again, that has a lot of statistical and methodologic issues. So I would say if you have early diabetes and you have somebody that's relatively young, let's say they're 35, 40 years old, but they're aggressively losing weight, their hemoglobin A1C is 6.2, their blood pressure is already 132, their LDL cholesterol is 60, I would consider that a relatively low-risk group of people. I'm not talking about the guy who's 65 with a BMI of 35, whose hemoglobin A1C is 8. No, that person needs to be down around 130 over 80.
No, these two groups are clear, but suppose a 45-year-old diabetic who is hypertensive,
Okay.
would you not say that he is high CV risk?
Oh no, I would say he is high CV risk, and I'm not leaving any of these people at 140. I'm suggesting that you get those people down. What I'm suggesting is that you don't shoot for 125, you shoot for 130.
George,
Yes.
I oversee the care of 36,000 patients with diabetes in the MRI system, and my primary care follows major primary care guidelines of 130 over 80, and the 88 comes 140 over 90 for most patients, and created a lot of confusion. So, and the question is, what is for next year guidelines of 88? Are we going to keep the 140 over 90 for most patients, and 130 over 80 for those with high risk, or are we trying to unify this world of confusion?
Well, no, I think what the concern is if you listen to AHA, everybody should be at 125 or 120. That's the thing. When they say less than 130, they mean well below 130. They really do. And what we tried to say, what I originally wanted to say, and I got vetoed, is to say a blood pressure range systolic of between 128 and 132, and people said, no, that'll confuse everybody. So, okay, fine. So much for bringing reality in. So yeah, less than 140 means less than 140. So if you're 134, 135, show me anywhere papers that will give you, if you're at 135 and I got you down to 128, forget the epidemiology, show me in you, that's going to make a big difference in terms of events. You can't. It's very difficult.
And what about the diastolic of 90? Isn't 90 really too high?
Well, first of all, the goal is less than 90, and yeah, 90 is high. But everybody, see, this is the thing. Everybody glommed onto this HOT trial stuff, and we knew about that years ago. Again, you have to be very careful. There's a subset analysis that was done from the main trial. So any statistician or a regulatory agency would throw that out, all right? So I think the reality is, since most people with diabetes, if you're looking at the young group, I think you need to be aggressive in them. But if you're looking at the older patients with stiff vessels, you know, they're coming into you already at 80. So, you know, are you okay? So, I mean, that's the problem. So I think you have to look at the risk, and I don't think there's any confusion. I think there's confusion because you're stuck on numbers. I'm saying forget the numbers, use clinical judgment, and look at the cardiovascular risk that person has. There is a calculator that you can use. It's free. You can download it on your app. And if they have high risk, then be my guest, get them down to blood pressures of 128, 130. That's what I do. But if, you know, if you're working hard and you're at 134, I'm not going to kill you to get you down to 128 because of some ethereal benefit. That's my point.
Nice talk, George.
Thank you.
Question for me. First of all, the British Hypertension Society guideline says that you should use ambulatory blood pressure monitoring to identify the patient with hypertension.
Yep.
And treating every patient. Is it feasible? That's question number one.
Yep.
Question number two, you talked about J-curve hypertension, especially in diabetic population. Is it because of the arteriosclerosis they get because of the hyperglycemia? There is an impairment of the microcirculation, and because of that, the artery stiffness, and that's why the return wave, which travels back and hits during diastole, therefore affects the perfusion of the coronaries, therefore causing high values of cardiac events. Is that the cause by ejection of
So,
pulmonary diabetes?
right. Right, so okay. So let's before I answer the J-curve issue, the first question was specifically what? What was your first question?
Question was regarding ambulatory reduction.
Oh, yeah, feasibility. So it's not just the British, the Americans have come out as well. The Institute of Medicine came out and said that all, not just diabetics, all people that are initially brought in and diagnosed as hypertensive should have an ABPM. The feasibility, I mean, I agree with that, but the feasibility is zero. There's no way that that's going to happen. And even in medical centers, if you don't have a hypertension center, good luck trying to get that done. So it's very difficult to do. So what do? Well, the soft way to deal with that is home blood pressures. So you give patients a machine, you have them measure it in the morning when they get up, you do it consistently for a couple of weeks and see what the values are. You teach them how to measure the pressure. And then once you do that, they give you the information, then you can use and it's practical. We do it all the time. He's going to get up and tell me it's not practical. And the reality, and insurance will pay for the machines. So I think it's important to get that information. And by the way, the daytime ABPMs have been validated against home blood pressures. They're just as good. So that's really a good way to get information in terms of where you're going with that. As far as the J-curve goes, there's really no, for people without diabetes, a lot of the old notions, well, diastolic gets down below 70 and all that, that's starting to be a little disproven. And in fact, I've got people without diabetes that have diastolics of 50, and they've been there for years. They're doing fine. So I think we're unclear on this. But in diabetes, yes, small vessel disease is very well known, microvascular disease. It's in the kidney, it's in the eye. Why isn't it in the heart? Of course it's there. So you don't know, exactly what's going on. Part of what you said as a theory is true in terms of the effects. But the other thing that's not appreciated is the coronaries have their own little autoregulatory mechanism. And when you get to diastolics of 45, they can shut off like that. And even the cardiologists that say there's no J-curve admit that. So there's a subset. This is a very small subset of people that I'm talking about. This is not for everybody. So I don't stop. If you have a systolic of 140 and your diastolic is 62, I'm going to push you a little bit more to see where you can go. I'm not going to stop at 140. But if I see, when I get you down to 135, 134, that your diastolic fell now to 50 or 52, I'm done. I'm not going any farther. Sure.
Very few times we have the chance to ask the oil experts hypertension questions, so forgive me for a second question. At least once or twice a day I'm in the clinic, I have a patient that says, "Doctor, my blood pressure is elevated because I didn't take my blood pressure today." This happens every single day. What do you do in those cases? When they don't see the patient but every 3 months,
Yeah.
and it's happened that today he didn't take it.
So those people are trying to get away with murder. So what I tell them, oh, no, because I've caught them. And I said, well, okay, that's fine. I understand. You forgot. Not a problem. Tomorrow and the next day, you're going to measure it, and you're going to email me the results. Or you're going to call me. And if you don't, then I know you're not measuring it. And then maybe I don't need to see you back because you're not cooperating. Trust me, that works. Anything else?
Thank you, Dr. Bakris, for a very interactive session. Now I invite Dr. Rajiv.
Thank you.